Con laws, you can sort of think of them as a permission slip that's granted by a government board to healthcare providers to expand services.
How else do you think certificate of need might affect access both in rural as well as in urban areas?
The purpose of con laws is more economic than health oriented.
So it sounds like in order for that to work, the certificate of need or the con boards would have to be aligned with that goal, right?
A competing story of how con boards operate, how con laws affect the healthcare market. I'm Liam Sigaud. I'm a research analyst at the Knee Regulatory Research Center at West Virginia University. I do research on health and public economics, and this is the Cause and Effect podcast.
This is the first podcast that we're doing. I'm really excited about this. Episode number 1. I'm interviewing my friend, Liam, who has worked with me for many years and is an exceptional researcher and economist. So I'm really excited to have this conversation. Liam, welcome to the show.
Thank you very much, Vitor. Thank you for the invitation. And let me just say the quality of the guests can only improve from here.
That's great. That's great. You're exceptional, and I don't think that's true. But let's get started. Okay, so we are discussing a paper that you wrote on certificate of need laws. So that's a very complicated name, certificate of need. I think most people are probably not very familiar with what these laws are, what they entail. They're also called con laws. People might have heard of them as con laws. So what are these laws? What are they about? What are their goals? Can you tell us a little bit about that?
Yeah, sure. So con laws, you can sort of think of them as a permission slip that's granted by a government board to healthcare providers to expand services. So this might be a hospital that's looking to build a new facility. It might be a nursing home looking to add more beds. Might be a doctor's office looking to buy an expensive piece of equipment. And providers, before doing these things, have to go before a board in some states and sort of make their case that this expansion of services is needed in the local community. And so these boards are supposed to apply different criteria to determine whether there's an economic need for the service. And I want to contrast those regulations, con regulations, with some other health regulations that people might be more familiar with. So things like occupational licensing law, making sure that doctors and nurses have the proper training to provide competent care, or facility licensing laws, things like making sure that a nursing home has enough fire extinguishers in the hallways. The hallways are wide enough. There are infection control protocols in place. Those are facility licensing regulations and occupational licensing regulations on specific workers. Both of those categories of regulations are sort of aimed at directly improving the quality of care, making sure the patients are safe when they receive healthcare services. The purpose of con laws is more economic than health oriented. It's really about whether a local community needs or would benefit from more services.
That sounds great. So could you talk a little more about because you talked about licensing laws, for example, occupational licensing, and how there are a lot of similarities there, right? How can you talk a little more about the policy goals of this different policies? So what are the stated goals or certificate of need laws? What are they trying to accomplish with that? How might that differ, for example, if you compare that to occupational licensing, for example?
Yeah, absolutely. And here, I think it can be informative to roll the clocks back to how con laws even started. So, in the 1960s, the Medicare and Medicaid programs, which are huge federal and state programs that provide health insurance to hundreds of millions of Americans, those programs were being created. And the creation of those programs coincided with just an explosion in health spending in the United States. So, for example, in 1960, before these programs were put in place, spending on hospitals in the U.S. was about $100 billion a year. By 1970, just 10 years later, a few years after these programs started rolling out, that had jumped to $230 billion. So more than a doubling in hospital spending in just a decade. And so this led to some concern in Congress and among policymakers that we might be overspending on services, that patients might be overconsuming services that don't necessarily add a whole lot to their health, but come at a great economic cost. And so Congress passed a statute called the National Health Planning and Resources Development Act in 1974. And this law sort of created incentives for states to implement con law. And the thinking was, if we can empower these boards to regulate the entry of hospitals into the market, so hospitals aren't just cropping up um, without any government say so, but if the government can provide some oversight, then the supply of healthcare services can be restricted in such a way as to limit health spending. So the primary goal of these laws was cost containment, to try to limit the growth of health spending. And now we have 50 plus years of evidence that suggests that they're not very good at that. For a variety of reasons, con laws have not limited health spending. And Congress sort of recognized that in the 1980s and removed those incentives that had led a lot of states to adopt con laws in the 1970s and early 1980s. And since then, there's sort of been a trend of states dismantling their con programs, reducing the number of services con laws apply to, and in some cases, doing away with them altogether.
Yeah, so you mentioned, for example, that one of the stated goals, so probably the primary stated goal, was to control costs. And something clearly connected with that is healthcare access. So, meaning if you have more services being provided, then that would imply that there could be more costs associated with those services, everything else held equal, right? So, what do you think would be the stated goal of policymakers with regards to access? And also, why do you think that's an important outcome to be examined?
Yeah, yeah. So one of the goals of the National Health Planning and Resources Development Act was to limit cost growth. But as you say, a secondary goal, and one that was emphasized in particular in rural areas, was to improve access to care. And the thinking there is that um, if you empower these con boards in states to regulate the entry of providers into the market, then you can, in some sense, divert investment that would have been invested in urban areas without the con board to rural
Mm,
areas. Because suppose you're a hospital looking to build a new facility, and it would be profitable to do so in both a rural area and an urban area, but it would be more profitable to do so in an urban area. It's more, there's a larger patient base. It's more, it's easier to attract the best doctors and the best healthcare providers. So your top preference would be to build a new hospital in an urban area. But let's say that the con board just vetoes that option, right? Denies you that con application and says you can't build it in the city, but
mm,
the whole rest of the state, the rural parts of the state, are open to you. And if that is a profitable option to you, then you might spend that money that would have otherwise gone to a city in a rural county and help that rural
yeah,
population acquire easier access to its healthcare services.
yeah. So it sounds like in order for that to work, the certificate of need or the con boards would have to be aligned with that goal, right? Because they have their own will and they can make their own decisions, right? So it sounds like they would need to be purposefully allocating or incentivizing providers to build more facilities or offer more services in rural areas, right? So do you think I guess what how else do you think this loss could affect both rural access and urban access. So before even talking about, empirical analysis, so where you actually look at the data and we examine, how else do you think we certificate of need might affect access both in rural and as well as in urban areas?
Right. So a competing story, sort of alongside the one I just sketched, where con boards serve to transfer investment from urban areas to rural areas. A competing story of how con boards operate and how con laws affect the healthcare market is that they essentially get captured by the interests of existing providers. So hospitals that are already in the market, they don't want more competitors driving down prices, stealing their patients. Right? That's the last thing they want. And so they exert pressure on con boards, both directly and indirectly through campaign contributions, through influencing the members of con boards, um, to suppress competition across the board. And so,
Mhm.
if that sort of hypothesis is correct, we would expect con laws not so much to transfer investment from urban areas to rural areas, but just suppress it across the board, right? Because hospitals in urban areas don't want competitors, hospitals in rural areas don't want competitors. So
Yeah.
these are the sort of the two. Sorry to cut you off. These are sort of the two competing stories, and then we can go to the data and try to tease out which is right in the real world.
Yeah, so it sounds like it really relies on what the com board looks like, right? So, do you know anything about how, like, who participates in those boards? Like, how do you get into one of those boards? Are there people from, is it politicians or people from the private sector? Who are these people?
Yeah. So you're right. It does vary state to state. Because these are for governmental boards, usually either the governor or the legislature, some other elected policymaker in the state is empowered
Mhm.
to appoint these members, and they mostly come from the healthcare industry of the state, and in some cases, they explicitly represent the interests of organizations that represent um, specific providers. So, an example is hospital associations. Every state has a hospital association that represents the hospitals in that state. They lobby the state legislature, they lobby Congress for policies that they favor. Um, the issue is that by putting these people on the con board, has enormous discretion in allowing new hospitals to be built in the state. And if you're giving decision making authority to people whose interests are to limit competition against other hospitals, the outcome is not necessarily going to be in the public interest.
Yeah, that's fascinating because, as you mentioned, the one of the stated goals, or at least when certificate really started in the 70s, was to make decisions based on what's best for the public, right? So we want to constrain or we want to reduce costs, and decisions should be made in order to improve overall healthcare quality as well as reducing your costs. But it sounds like a lot of the people involved in those boards are, deeply or closely related or closely associated with the providers. So the people who are making money off of the system, as opposed to, just being, a member of the public or somebody who only has the public in mind. That's really interesting. So we talked a lot about certificate of need, right? But your paper is about how certificate of need affects access. So what do you mean by access? And so you talk about both rural as well as urban access, right? So what do you mean by that? And why should we care about it? Is that a problem at all, for example, in the United States right now?
Yeah, so I think looking at the urban rural divide in healthcare access is really critical because there's a huge difference in terms of access to specialty services, hospital care, um, other types of health resources between, let's say, someone living in a rural county in West Virginia and someone living in New York City. Um, and obviously these differences can have downstream effects on people's health, mortality, how quickly they can get care when they get sick, etc. So access is really key to try to get the U.S. health system to function better for all residents of the United States, no matter where they live.
Yeah. So by access, do we mean people having the ability to go to hospitals, or is it, if you live an hour away from a hospital and you have an emergency or you're having a baby or anything like that, that would be difficult, right? for you to access there. So, in your specific research, what do you mean by access, and what do we know about how access affects people's actually, their actual health outcomes, and just living standards in general? So, meaning, if somebody lives an hour, 2 hours away from the closest urgent care center or hospital, does that really affect their quality of life or their health outcomes? So, meaning, why should we care about how close, for example, people are to healthcare providers if that's what you mean by access?
Yeah, so like you mentioned, you can define access many different ways. Some research looks at driving times, which is a really important parameter in a lot of areas. In this paper, we sort of kept it simple, and we looked at whether there were we looked at the number of hospitals per 100,000 people living in a given rural or urban area. We looked at the number of
Mhm.
hospitals per population, and we looked at the number of hospital beds per population.
Hmm.
And so, both of those speak to how easily and how quickly people can get their medical needs met. And to your point about, whether access really matters down the road, there's a very large literature on this. Some care is obviously more important than other types of care. There's low value care, there's high value care, but in general, people in rural areas, the evidence shows part of the reason why their life expectancy tends to be shorter and they struggle with more chronic disease is because they don't have as much access to providers as people in urban areas.
Hmm. So it sounds like, yeah, and I think probably the general any person on the street, if you ask them, would you like to be, 5 minutes away from a hospital or an hour away? I think people would like to be somewhat close, right? So it seems obvious, but it's good to know that there is research also showing that if people are closer to a healthcare provider, that's a good thing for their health, and that makes total sense. So, what's the specific question that you guys look at in the paper?
Yeah. So, like I mentioned earlier, starting in the 1980s and continuing through the 90s and the 2000s, states started dismantling their con programs and reducing the number of services that their con regulations applied to. And one of the things that got deregulated in a lot of states was con oversight of hospitals. And so, what
Mhm.
we do in this paper is we look at 5 states from the early 1990s through 2019, 5 states that removed their con laws related to hospitals. So 4 states did so in the 1990s: North Dakota, Pennsylvania, Nebraska, and Ohio. And then one more state did so in 2016, and that was New Hampshire. So we look at those 5 states and we compare them to states that kept con laws for hospitals throughout that period. So if you think of a sort of traditional experiment that a scientist might conduct in his lab, right? You have 2 groups. You have a control group that doesn't get treated with anything, and then you have a treatment group that you apply the intervention to. And it might be a drug, or it might be um, a particular intervention that you're interested in measuring the effect of. And you would compare the outcomes of those 2 groups, and whatever difference you find, you would attribute to the effect of the treatment. Well, what we did in this paper was sort of in the spirit of that. Obviously, you can't randomly assign one state to keep or repeal its con laws and other states to do the opposite. But what you can do when a state repeals its con law related to hospitals, you can compare how the outcome you're interested in, for example, the number of hospitals in the state, changes, and compare that to states where nothing changed. And that
Oh.
way you can sort of tease out what the effect might be.
Yeah, so people could just look. So we could just go and look at, in 2025, when we look at states that have certificate of need laws and states that don't, and we could just compare the number of, hospitals that they have in rural areas per capita, of course, and urban areas, right? Um, and so this podcast is called The Cause and Effect. So we're interested in understanding the actual effect of these policies. So why didn't you guys take this approach?
Yeah, so those simple comparisons, where you just compare sort of snapshot in time 2 different groups, can be useful and can suggest that a particular policy has an effect. The problem is that a lot of different things are changing at the same time. So states don't
Mhm.
just differ in the con laws that they have related to hospitals, right? They differ in all kinds of laws that apply to their labor markets, that apply to their healthcare system. Their populations look different. Some states have older populations, some younger. Some populations might have different health behaviors that affect downstream health outcomes, that affect people's to access care. All
Yeah.
of these things contribute to the outcome you're looking at. And so it's hard to see whether it's the con law that's making the difference
Yeah.
or it's any of these other factors.
Yeah, that's a great way to describe it, right? Because what you're doing is you're interested in looking at the effects of one change in that policy, right? And your empirical analysis basically allows you just to estimate, what would happen if this state didn't change this law, right? What would happen if they didn't change certificate of need? Um, and then you compare that what happens in reality to what would have happened. So you actually are able to understand the cause of this, and that's what we're interested in the podcast. So that's a great example and explanation. So what do you guys find?
Yeah, so like I mentioned, we look at hospitals per capita, we look at the number of hospital beds per capita, and then we
Mhm.
look at a third outcome, which is sort of the first variable divided by the other variable, which is the average number of beds per hospital, to get a sense of whether hospitals are getting bigger on average or smaller on average. And what we find is that the number of hospital facilities per capita goes up by a fairly large amount in both rural and urban areas. So if you go back to the sort of competing stories that I described, where on the one hand, con laws might be helping to divert investment away from urban areas and towards rural areas. And on the other hand, con laws might be operating to reduce supply of hospitals across the board. The fact that we find that removing con laws causes the number of hospitals per capita to increase in both rural and urban areas sort of gives credence to the second story, to the story
Mhm.
where existing providers are using con laws to limit competition across the board. Because otherwise, if the first story was correct, you would expect that if you removed con laws, investment would start flowing into urban areas at the cost of the rural areas, right? So you might see a reduction or at least a flatlining of the number of hospitals in rural areas and a big increase in urban areas. But you don't. You also see an increase in rural areas when you remove con laws.
So it sounds like if you repeal, or at least in all the cases that you analyze, so 5 states, that's actually quite a lot of states changing their laws. Um, so it sounds like if the repeal leads to an increase in the number of hospitals in both rural and urban areas, why do you think so many states, or actually, what should states expect if they also repeal their laws, right? So this is one result that you talked about is with regards to the number of hospitals. What else should we expect that might matter for rural access?
Yeah. So we also looked at the number of hospital beds per capita.
Mhm.
And there, again, in both rural and urban areas, the story is sort of consistent. We see the number of hospital beds per capita decline.
Hmm.
And so when we also when you sort of combine those two effects and look at the average size of facilities, we see that go down as well. And so what one interpretation of that is that the market the new facilities that are entering the market now that the con law has been repealed and it's easier to build a new hospital, those new facilities are smaller than existing providers. And that's sort of consistent with the idea that existing providers, especially large hospitals, have large amounts of resources to devote to lobbying, to political influence, to court cases, and going through the bureaucratic and administrative steps in the con process. And the little providers aren't so adept at that. And so those were the ones that were kept out of the market when the con law was in place. You remove that and they come flooding in.
Hmm. So it sounds like you would have the repeal, if a given state, for example, repeals certificate of need, you would get more hospitals, but smaller hospitals on average, right? Yeah.
Yes.
So what do you think that means for access then? Because people can think of having more beds as, yeah, a good thing. We also think, of course, of having more hospitals is a good thing. Um, so do you think the repeal leads to better access to care by, meaning that having more hospitals but smaller hospitals on average, is that a good thing or a bad thing?
Yeah, I think that's a really important question. And in rural areas in particular, which is sort of what a lot of policymakers worry about, because that's, like I mentioned, that's where access to care problems are particularly acute. In rural
Hmm.
areas, I think the increase in hospitals, but as you say, their small size is generally beneficial. Because what a
Hmm.
lot of rural areas and rural residents face is really long driving times to any provider. And so, if you have, an emergency, if you need urgent care of some kind, you really face a long delay in getting that problem looked at. And the increase in the number of hospitals, though they might be small in rural areas, reduces driving times, or would be expected to reduce driving times for a lot of rural residents, which would give them access to some care. Maybe not the most sophisticated care. A lot of these hospitals are not going to have, the
Yeah.
top level trauma units, but enough to stabilize a patient and maybe transfer them to a more sophisticated care setting.
Yeah. So what does that mean then about, so for example, you repeal certificate of need laws and you get more hospitals, but they are smaller on average. What do you think that means for competition? So you guys mentioned competition in the paper and how this could be, your results can be at least suggestive of some changes in competition, and how competition in the healthcare market. So many firms are competing with each other for customers. So in this case, hospitals are competing for customers, how that might look like with certificate of need and without certificate of need.
Yeah. So our paper provides some suggestive evidence that certificate of need suppresses competition, and that removing them by increasing the number of providers intensifies competition. And that and a lot of research has been done on competition in the hospital market and in the healthcare sector. And the overwhelming conclusion is that competition is very beneficial for patients. When hospitals compete with each other, they compete on price, which means they provide a cheaper, less expensive service to patients. They compete on quality, trying to provide the very best outcomes to patients. And so, in markets that are very concentrated, which is to say, there are very few providers in a given area accessible to patients, and so they're able to say it's our way or the highway to the population. You see prices going up pretty dramatically. And oftentimes you see a deterioration in quality because there just isn't that pressure to deliver for the patient.
Yeah, so it sounds like from everything you're saying, the repealing certificate of need leads to more competition then potentially, right? Meaning you have fewer hospitals, more hospitals, sorry, with fewer beds. So there that could be indicative that they're competing more with each other. You just don't have, one or a few big guys, right? There's also just more hospitals in general. So many people are going to live closer to a hospital on average. So all of that seems to suggest we might not want to have those policies, right? So what else do we know about certificate of need? So stepping away a little bit from the paper and talking about different research projects that you cite. So what else do we know about certificate of need that you think could be relevant to policymakers?
Yeah, so there really is a huge literature on certificate of need because these laws have been around for more than half a century, and a whole host of outcomes have been looked at. The original
Mhm.
intent of those laws, like we mentioned, was containing costs. A lot of studies have looked to see if they were effective in that regard. Other studies have looked at access, like ours. Other studies have looked at quality of care and outcomes like readmission rates or mortality after hospitalization. And there are some mixed findings in the literature, to be sure. I don't want to paint it as a completely one-sided conclusion, but I think it's fair to say that the overwhelming majority of these studies, many of which are very carefully done,
Yeah.
um, suggest that removing con laws leads to better outcomes for patients. So leads to care that's more affordable, care that's higher quality, and care that's more accessible. There are more facilities available. Driving times tend to be shorter, and across other measures of access, patients can get the care they need more easily. Um, that's the general conclusion.
So you just described a lot of different projects and a lot of different analysis done on certificate of need, but it sounds like very few people know about this policy, right? So even economists, I know many economists who've never heard about this. I myself had not heard about it until really, 3 4 years ago. um so I wonder, why do you think so few people know about certificate of need? Certainly people who are not studying healthcare very closely don't think too much about that or might not be aware of it. Why do you think people are not aware of it?
Yeah, I think awareness is growing, but you're right. I think historically there have been sort of a small group of researchers focusing on this, and they've not necessarily attracted the attention of their colleagues in health economics as much as might have been justified by the importance of these
Yeah.
regulations. I think one explanation is that um, reforms to the demand side of healthcare, if you will, changes that expand health coverage, for instance, have been prioritized at the federal level. So the Affordable Care Act, which is the major health reform of the last quarter century, um, it didn't deal very much or at all with certificate need loss, but it didn't even deal with facility licensing or barriers to entry um, in a direct way. It was focused on expanding healthcare coverage to Americans who were uninsured previously, and that's an important objective.
Yeah.
And it that law led to enormous interest in studying its effects on different populations and subgroups, and now we know a lot about what that expansion of insurance coverage led to. But it sort of shifted attention away from these other policies that are also super important.
Yeah, and a connected question then is, and perhaps the answer to that question is that very few people know about it. But I think the main question here is, if there is so much research showing that certificate of need does not lead to better health outcomes and possibly leads to worse health outcomes, and I mean, not to mention other things like access that you we just talked about, as well as costs. Why do you think so many states still have it? So actually, a majority. I was looking this up right before the interview, but the overall majority of states still has some type of certificate of need law. There have been a few. So West Virginia reformed their law. South Carolina repealed almost all of their laws recently, but those are fairly rare events. Like looking at the past 2 decades, there are very few states um, substantially changing those laws or repealing those. So why do you think that is? If there is so much research showing all of this effects and how this laws might not actually be benefiting the general public.
Yeah, I think the main explanation, to be honest, is that the healthcare sector is has a lot of sway politically in a lot of these states.
Mhm.
So health spending commonly accounts for 15 to 20% of a state's economy, a huge proportion of its employment in some communities. Right when a hospital um, faces competitors and might go out of business if it can't compete for customers, or has to shrink, um, potentially hundreds of people lose their jobs. So, although this sort of dynamism and competition in the healthcare sector overall, I think is very beneficial for patients, politicians worry that um, their constituents might be unhappy if they allow these existing hospitals to face too many competitors. And so that gives hospital associations and hospital CEOs a lot of power to say, look, to their local politicians, we won't support you anymore, and we'll let your constituents know that you're potentially, um, repealing this con law, and so exposing them to more competition. And politicians react to those incentives.
Yeah, so it really sounds like the benefits of certificate of need are very concentrated, right? So there are some perhaps very large hospitals implied for your research that really benefit from certificate of need, right? So they face less competition. They might be able to remain as large as they are because there aren't alternative hospitals for people to go to. So there are very concentrated benefits, and those people might be more likely to influence, politicians than the general public, right? So the cost, it seems like the cost, for example, if you have fewer hospitals in rural areas, everybody in those rural areas, or most people at least, are going to be hurt by this. But it's probably unlikely that they're going to be lobbying or, really even be aware that this policy could be affecting that. Do you think that's a reasonable description of what could be going on here?
Yeah, absolutely. I think, when you have, and it's not unique to the certificate of need laws, to be sure, there are other policy areas where a small group of people benefit from a policy that comes at the cost of a much larger group, but each individual in that larger group faces a cost that's so small that it's not really enough to motivate them to engage politically and make that the decisive factor in deciding who they elect, for instance. And so that larger group remains fairly apathetic to the policy, and the small concentrated interest is able to get its way.
So somebody at home who's listening to this and is just learning about certificate of need laws, right? And what this could mean, because they clearly the outcomes you're talking about, they clearly affect millions of people in the US right now. Um, so what do you think somebody like that, somebody like that might be thinking, what can I do? What can people do in order to change this? I know you've been involved in policy, you've written testimonies and so on. Um, what do you think are the prospects in terms of things changing, and what do you think is a possible way that laws can change? Is it do we need more evidence? Do we need better evidence on the causal effects of these laws, or do you think there are other factors that might be playing a bigger role, and perhaps it's not just we already have a lot of the evidence that we need?
Yeah, I mean, as a researcher, I'll never say that we have enough evidence. I think there are always interesting projects to pursue, and there are details about how con laws affect certain services or sectors
Mhm.
that are still fascinating to explore, and certainly there's more to learn. But I think the
Yeah.
evidence base is very strong to justify big reforms in a lot of states. So some states are have extremely restrictive con laws that apply to a whole host of services, and that are almost certainly not in the public interest. Um, and in terms of what the average person can do, a lot of these states have bills in their legislatures that are looking to reform either a part of con laws or get rid of them wholesale. And the public is welcome to chime in and submit testimony to your local representative, and to the committee that oversees that bill, and let your voice be heard as a consumer and as a patient, that you're interested in seeing these laws looked at and potentially repealed.
Yeah, so it seems like there's a lot of research on a lot of different topics, right? So you talked about how certificate of need laws might affect access. That was the main topic here, but also quality, but also costs. Um, what else do you think we might want to know about? So somebody wants to know about the effects of this law. What other outcomes do you think could matter? And perhaps there isn't a lot of research being done on it yet.
Yeah, so I think continuing on the access point, one thing like we talked about in rural areas, a big thing, a big impediment to a lot of patients is getting to a provider quickly when you have an emergency. And so, one project that I'm pursuing now is to look at the effect of repealing con laws on things like traffic accident mortality in rural areas. Because here we have a case where someone gets into a car crash, sustains a potentially life-threatening injury, and you have very little time to get that person to an appropriate medical facility to get the care they need to potentially save their life. So that's one sort of margin that might be super relevant for seeing how con laws affect rural populations. And motor vehicle accident deaths are the leading cause of death for Americans under the age of 55. So this is a huge problem in urban areas and rural areas. So
Yeah.
if con laws contribute to this, um, then that's yet another reason to look at them and give them a really hard look.
Yeah, that's fascinating. So, if somebody wants to learn more about certificate of need laws, or what those laws might look like in their state, or what's going on really, with current policies, as well as research looking at their effects, what do you recommend to somebody who just wants to learn more and might not be super familiar with the laws?
Yeah, they can check out the Knee Regulatory Research Center. My colleagues and I have put out a ton of research on certificate of need laws in different states, looking at different outcomes, summarizing a lot of the evidence from earlier research. So that would be a great place to start.
Awesome. Leah, thank you so much for joining the show and for giving all this great insight about this law. I think hopefully, a lot more people will be talking about that in the near future. And we're trying to do all we can to make sure people are aware that these laws exist and that there's actually a lot of research on that. So thanks for taking the time to join the show and share more about your research.
My pleasure. Thank you, Vitor.
Before you leave, there are two things I want to tell you though. So the first one is, if you're new to the show, please subscribe and like. I really appreciate your support. It means the world if you can subscribe and share with people in your network, okay? So please like and subscribe. I really appreciate it. And then the second thing is, the podcast is only made possible by the generous support of the Knee Regulatory Research Center at West Virginia University. So they do a lot of research on different topics, different policies, and they're interested in understanding the cause and effect of government policies and programs, and understanding important economic problems. So if you're interested in those topics, check out their website. It's going to be linked to the description. And thank you so much for your support.